Hi all, welcome to Study MRCEM OSCE MME series. Today we'll be discussing chest drain catheterization and airway adjuncts. So first we'll start with what will be the procedure. The first thing that you have to do is in every procedure station we'll be dividing the station into three: pre-procedure, procedure, and post-procedure. In the pre-procedure, we will explain indications, contraindications, complication, how to treat the complication. In the procedure section, we'll explain how preparation of the equipment, preparation of the patient, preparation of the doctor, positioning the patient, and the procedure. And post procedure will explain how we'll monitor the patient, what are the documentation required, and what is the post procedure advice and post procedure follow up. The station can come in different ways. Sometimes it can be you and a patient. Sometimes it can be you, a junior doctor, and the patient. Sometimes it can be you, junior doctor, and a mannequin. So the same station can come in different ways. In StudyMEDIC will help you prepare for everything, and you'll be fully prepared to face any station. In our live course, also we'll be discussing these things in detail. Moving to chest drain, we have both open technique and cell degree technique. Here I'll be discussing the open technique. The indications for chest drain are pneumothorax, large pneumothorax causing symptoms, and tension pneumothorax. For tension pneumothorax, if it is a tension pneumothorax, we'll have to do needle decompression first. Then only we'll proceed into chest drain. Because needle decompression is a dire emergency in that situation, and we have to do it. Where do we do the needle decompression? For adults, in the fifth intercostal space in the anterior axillary line. For children, in the second intercostal space in the mid clavicular. In failed aspiration in spontaneous pneumothorax, also we'll have to do chest drain. Any ventilated patient with pneumothorax, massive hemothorax, large symptomatic effusion. These are the indications for pneumothorax. Contraindications are bleeding disorders, skin infections. But since it's a life-saving procedure, we won't mind the contraindications. Even if there is a little contraindications, we'll do the necessary things and go ahead with the procedure. If the patient is having bleeding disorder, we might arrange blood FFPs and do the procedure. Complications can be pain, infection, bleeding, local anesthesia toxicity, intrathoracic injury. How do we prevent the complication? We prevent the complication by using, for pain we'll be giving pain medications, we'll be giving local anesthetics. To avoid infection, we'll be doing it in a sterile environment using sterile equipment and the sterile technique. For local anesthesia toxicity, that's a major complication that can appear. To avoid that, we'll be using the correct dosage of the local anesthetics. We will be using it, reduce the dose in the extremes of ages, and we'll be injecting it by aspiration and then injection, aspirate, inject, so that we ensure it is not injected into the vascular space. And if there is any local anesthesia toxicity, we'll move the patient to a resuscitation area, connect him to high flow oxygen, and give him fluids. If if the patient goes into RS, we can give him intralipid. To avoid intrathoracic injury, we'll be approaching the patient through the safe triangle. Also, we'll be to avoid the neurovascular bundle, we'll be inserting through the upper border of the lower rib. In the thoracic cavity, the neurovascular bundle passes through the lower border of the upper rib. So while putting the chest in, we'll go through the upper border of the lower rib. These are the things that we'll do to prevent the complication. These are the pre-procedure things that I explained just now. Moving on to the procedure, we will initially prepare the patient. Before that, we have to confirm the side of the pneumothorax or hemothorax by examining the patient and checking the X-ray. We'll take a brief history, do an examination, inspection, palpation, percussion, and auscultation, and also check the X-ray to confirm the diagnosis. Then we'll identify the safe triangle. Anteriorly, it is by the lateral edge of the pectoralis major. So, posteriorly by the lateral edge of latissimus dorsi, so superiorly by axilla, inferiorly by the fifth intercostal space. We'll identify the safe triangle. We'll position the patient. Patient will be in supine position with the hand behind his head, and he will ensure that he's in a well-monitored area, and you have every necessary equipment prepared. He is connected to the monitor. Saturations and vitals are being monitored. Going on to the procedure, for chest drain open technique, we'll make a skin incision. Then we have to clean the area, drape the area. We have to mention those things and preparation of ourselves. Like we'll clean our hands, wash our hands, wear our gloves and personal protective equipments. Then we'll move with the procedure. Initially, we'll give the local anesthetic, lidocaine, if it is with adrenaline, 7 mg per kg. Without adrenaline, 3 mg per kg, the maximum dose. We'll reduce the dose in extremes of ages. Then we'll move ahead with the procedure. For chest drain open technique, we'll do a skin incision which is 2 to 3 centimeter at the upper part of the lower rib, usually in the fifth intercostal space. And we'll do a blunt dissection with artery forceps. We'll do a finger sweep. And we'll once we pierce the parietal pleura, we'll place the drain in the position. Once we place the drain in the position, we'll connect it to the underwater seal, check for bubbling or swinging of air in the air fluid in the air column, and secure the tube by suturing. Here sometimes we'll have to demonstrate where we are doing the procedure, how we are doing the procedure. Sometimes we might have to do the procedure itself. After the procedure, we have to ensure that the air fluid column is moving, and then we have to examine the patient again. We'll examine the inspection, palpation, percussion, auscultation, and we'll take a check X-ray. We'll see how the patient is improving. After that, we'll dispose the PP and equipments in the respective bins and document all the procedure. What are the post-procedure advice that we can give to the patient? To ensure that it doesn't get pulled out, and once the air fluid column is the fluid is drained or the chest is back to its normal position, we'll remove the chest drain. These are the things that we have to ensure in chest drain open technique. In Seldinger technique, the incision will be just a simple 2 to 3 mm incision. It's a very small incision. Moving to urinary catheterization, this is also a very important topic, and this thing you most probably will have to do in a mannequin. And the most important thing is that it should be a sterile technique, and you must not touch the urinary catheter with your hand. That is the most important thing. With your bare hand, you can't touch the urinary catheter. It must be inserted without touching, like we do in the hospitals here. Also, we do like that. Please ensure you do it in the correct way. I'll just brief you. In our live session, we'll be discussing this in detail. In every station, we have to greet. Whenever we enter, greet the, if there is a junior doctor, greet the junior doctor. Hi, good morning. I am Dr. So-and-so, the emergency registrar. May I know your name and age, please? Nice to meet you. How are you today? Even if it's a patient, you have to tell these things. Then we'll go and we'll explain. If there is a patient, we'll explain why we are putting. If there is a staff, also we'll explain. I need to insert a thin flexible tube into your urethra to drain urine, and you will be awake during the procedure. To avoid any pain, we'll be giving you local anesthetic, and we'll be doing it in a sterile technique. Indications for urinary catheterizations are urine retention, urinary bladder irrigation, input-output charting. Contraindications are urethral trauma, acute prostatitis. Complications are failure of the procedure, urethral trauma can happen, catheter-related infections can happen. To avoid the complication, we'll do it in a strict sterile environment. To avoid trauma, we'll inflate the urinary catheter only after we see urine coming out through the urinary catheter. And if there is any other complication arising, we'll contact with the urologist. Initially, we'll wear 2 gloves and hold the shaft of, using a sterile gauze. We'll hold the shaft of the penis, pull back the glands, pull back the foreskin, and clean the glands area. After that, we'll put a whole towel. Then we'll remove our 1 glove. Or else, initially we can wear 1 glove, remove that glove, and wear another glove. Here, initially we wore 2 gloves, so we'll put the whole towel and remove 1 glove. Then we'll hold the shaft with the gauze, and we have already cleaned the glands area. We'll push local anesthetic. It is given for anesthesia, for lubrication, and to check if there is any obstruction. And we'll massage through the urethra. Then we'll open the catheter valve. We'll ask our assistant or the nurse assisting us to open the catheter valve. We must not, we'll hold the catheter in the plastic area. There will be an area on top which can be pulled. So the catheter is open. And we'll be still holding the plastic wrap itself. We won't be holding the catheter with our hand. Then we'll insert the catheter into the urethra slowly, and ensuring that every time you must be sure that you are not touching the catheter with your hand. Once it is inside the urethra and the urine is coming, you'll hold the catheter at the Y limb is there, right? In the end, where we have a port to inflate the balloon and to connect the urinary bag. There we'll hold. And after inflating, we'll pull the catheter back. Why are we pulling the catheter back after inflating? It is to avoid catheter tip touching the bladder wall. Then we'll dispose the equipments, glove and equipments in the respective bin, and document the procedure. If there is any bleeding, during the procedure or after the procedure, we'll deflate and remove the catheter and call urologist. If there is any resistance in doing the procedure, don't do extra force and do the procedure. Don't do the procedure, stop it there and call the urologist. If there is severe pain, give painkiller, call urologist. And before any procedure, we have to ensure that all the equipments are within the expiry date. We must check the expiry date of the equipments. Here is the catheter, there the chest drain tube, everything we have to check. Now moving on to airway adjuncts, it can be asked as an individual station about airway adjuncts to teach a junior doctor, or basic airway management can be asked. Anything can be asked in that case, and it is very important to know about airway adjuncts. Airway adjuncts are mainly oropharyngeal airway and nasopharyngeal airway. It is used to maintain the airway. How will we measure the size of the oral pharyngeal airway? It is very important to know that to understand how to measure the size, how to insert. The indications and contraindications you might be knowing it. The oropharyngeal airway, it is measured from the incisor to the angle of mandible. From the incisor to the angle of mandible, we measure. In adult, we insert it upside down, and once we reach the soft palate or touch the posterior pharyngeal wall, we'll turn it 180 degree. That is how we insert an adult. In pediatrics, we can insert it directly without rotating. We use a tongue depressor, push the tongue down, and then we can insert it directly without rotating. Or we can insert it at 90 degree and rotate it when we reach the soft palate or posterior pharyngeal wall. OPA is inserted if no gag reflex is present. If the patient is conscious, don't attempt oropharyngeal airway because it can induce vomiting. Okay. It is if the patient is tolerating OPA, then chances are high that he might go into an advanced airway. Now, nasopharyngeal airway, it is used in main thing is don't use if the patient is not tolerating oropharyngeal airway, if he's conscious, we can go with nasopharyngeal airway. But in case of nasopharyngeal airway, we can't use it in head trauma patients or basal skull fracture. And we can use in conscious patient and seizure patients also. We can use nasopharyngeal airway because it will be difficult in seizure patients to put a oropharyngeal airway. For nasopharyngeal airway, we will measure it from the nostril to the tragus of the air. We will lubricate the nasopharyngeal airway and insert it perpendicular. These are the things of airway adjuncts. In our live session, we'll be discussing with these things in detail and different types of station that you can expect and how you can face it and how to deal with different stations and how you can clear the exam with confidence. Thank you.